Well, good morning, everybody, and good afternoon for the ones that are on the west side of the world. It's a real honor, but I'm also sad that this is going to be our last presentation. I'm hopeful that there will be more to come. This is actually a topic that I personally enjoy very much, and it's an area where I have spent a good amount of time, and most of my research has been done in hypospadias. So this has my complete biased appreciation of hypospadias. So disclosures, I have to just simply acknowledge to you that I'm a member of the SPU Hypospadias Task Force, and that role involves some steps that have changed the way I see hypospadias and how I believe we should move forward in the care of our patient. Um, I have no financial disclosures, and I'm a father of two boys, Tomas and Jeronimo. And of course, that also has changed the way I see hypospadias and the way I counsel families as well. So for the presentation, the images that you will see are either drawings that I have done, like this one, or that are pictures that we have consent from the families, and they have all been included in an anonymous way. Historically, we have classified hypospadias based on the location of the meatus. The first description of a classification system was back in 1936 by Brown, who initially classified hypospadias based on the location of the meatus. And he gave an anatomical description and classified it in this glandular, subcoronal, midshaft, penoscrotal, midscrotal, and perineal. And then almost simultaneously, Smith proposed the degree classification, and he divided into three main categories: distal, mid, and proximal. And then Schaefer and Arps in the 1950s changed that degree classification into an anatomical one. And more recently, after this anatomical description of hypospadias had been the gold standard for classifying hypospadias, Duckett actually changed the perspective, and he included the key component of classifying hypospadias after degloving the penis during surgery, and that was in the 1960s. More recently, we have been focusing on anatomical variables that have shown to be predictors of surgical outcomes. And Merriman recently in 2013 proposed the GMS scoring system. There are other additional scoring systems like the HOPE one, but they have all been focusing on the anatomy. And right now, the most wide used scoring system is the GMS score, which involves classifying hypospadias based on the glans, a subjective appreciation of the glans, the meatus location, following the previous principles and classifications from the authors that I mentioned before, and also the presence of penile curvature. With all that, they have been seeing that the complication rate for patients with a GMS score of 6 or less, it's very low compared to those that have higher scores. So why is this so important? So first of all, I think the issue with how we have been classifying hypospadias has impacted the way we analyze all the epidemiological studies. Prevalence has always been reported using this classification systems, but there is variability in how the literature has reported it. We I participated in this worldwide study where we looked at the prevalence trends of hypospadias worldwide since 1980 until 2010. And one of the most difficult challenges that we had was that we did not easily identify a common phenotypic description of the anomalies in all those surveillance systems. So, in other words, it was very difficult to compare the data that had been collected in different parts of the world. So, this is one reason that I think has impacted the way we interpret hypospadias. On another hand, surgical techniques and outcomes have always been reported using this same classification system. Initially, long ago, mostly in Europe, the distal hypospadias, where the meatus was located at the glans, they were not included as hypospadias diagnosis. And only until Dockett proposed the MACPI procedure, the hypospadia started to be classified into including the distal glandular ones. So does location of the meatus predict surgical outcomes? I think we have seen that it does, but I'm not sure if we're seeing things correctly. And I wanted to bring this author who I think has a very interesting quote. And he, George Santayana, who's a Spanish writer who lived in the U.S., he wrote this quote, and he said, "Those who cannot remember the past are condemned to repeat it." And I think if we continue to look at the anatomy the way we have been doing it forever, I think we may not be able to advance the field of hypospadias. So should we continue to focus on variables that make decisions about how to refer to hypospadias? I think one of the phrases that I heard from one of my mentors once changed the way I see hypospadias. And she said that hypospadias surgery is an artistic process. And that's the perfect place where art joins science. It requires a high level of technical dexterity to master the procedure. It requires training, and we know that there have been publications saying that at least you need 50 cases to achieve the learning curve to be independent. But it also requires innate talent. And you all know that there are surgeons that are more capable technically than others. And also, I think one of the things that it has been very difficult to learn is the thinking process that you have to do when you're doing a reconstruction in hypospadias. It's a surgery that it's really difficult to reproduce, and you pretty much have to improvise during the surgery. It's really hard to make it a standard surgery in the way that has been published by many authors. So it requires some sort of imagination and creativity. And historically, hypospadias it's the surgeons that have mastered hypospadias. I think they can be compared to artists. So let's say that I'm in the operating room. I'm doing this surgery of hypospadias, regardless of how proximal it is. I have to include in my thinking process where's the meatal location to make a decision on which technique do I need to use. Also, I have to take into account the gland size and see if I'm going to be able to tubularize the urethral plate. I have to look at the urethral plate quality, which is very subjective, and see if it's wide enough and if it's grooved enough to do the reconstruction. Also, I have to take into account how severe the ventral curvature is, because I may need to do additional steps during the surgery. And that requires experience, but also unconscious thinking about how I select the tissue. but I'm not PP Sally. I'm not a surgeon with great experience. And I think if we want to teach our fellows and residents and junior faculty about how to improve and reduce the complications rates, we need to find a good balance to predict how we do surgery. So hypospadias requires mastering, but also requires that ability to have a good imagination. So with regards to the classification systems, um, anatomical variables, as we have done so far, are critical, and I think we have to continue to involve them in our thinking process when we're doing surgery. But I think we have to think about the anatomical variables in a different way. I think we need to start involving the genetics into our surgical planning. And one of the things is we need to see how we can see the expression of the genotype and how that will manifest into the phenotype. In other words, a good example is, for example, the gland size, if that will be a reflection of the androgen input or any hormonal input during development. We know that there are patients that benefit from testosterone injections preoperatively and others that don't. There are some that have anatomical changes with the treatment and others that don't. And there has been a good amount of literature supporting that androgen therapy may increase the complication rate. So I think if we can understand how the genotype impacts the phenotype, we will be making that next level of understanding and will improve how we do surgery. The microscopic quality of the tissues is something that has not been thoroughly explored. There were initial studies looking at the urethral plate vasculature and the tissue and the possible presence of scar tissue, but I don't think we have thoroughly explored the anatomy microscopically up front. And I think we need to focus more on that. And I will definitely deep dive into that more specifically in a few slides. Genetic variants, I think we have to start thinking up front that we may need to understand better the genetics of our patients. So far, their medical indication to do genetic testing is for those patients with proximal hypospadias that may be considered in the category of disorders of sexual development. But I want to talk about that also in a few slides. The impact on genes, we have been looking at the gene that causes hypospadias, but we have not seen how those abnormal genes interact with wound healing. We know that patients heal better depending on their hormonal input. So I think this is another area that we should look into. Identifying hypospadias, I think, will also depend on the genotype. And we may need to start classifying hypospadias based on the genotype and not only on where the location of the meatus is. So in other words, we know that there are patients with the same mutation, but with a different location of the meatus. So maybe if we look at the genotype, we will be able to classify them better and predict how they will do surgically. The tissue response to therapies. We can also upfront, if we do genetic testing, can say this patient will benefit from therapy. For example, if there is a mutation on the androgen receptor, let's not give them testosterone. They may not respond to therapy, for example. And the next level, I think, is understanding the quality of the tissue with using imaging technologies that will guide us on how to better select the tissue that we're using for surgery. Then biomechanical properties are going to be very important, and I have a few slides about those in the next few slides. And machine learning, I think it's a novel technology of artificial intelligence that can probably help us understand this better. This is actually a slide that I did and presented during my PhD thesis defense. And The interesting thing is, I wanted to highlight at that point, and that was back in 2016, that we know that there have been around 27 genes described in hypospadias, and they're spread throughout the entire genome. The thing is that more recent data has started to identify more genes involved. So I think historically we were initially limited by the fact that we were looking for the gene that would cause hypospadias, but more recently with the massive sequencing technologies that are available that are more affordable, we have started to identify the presence of multiple different mutations. So this is a probably a condition that it's the expression of multiple different anomalies. So for surgical outcomes, I think we can say that if we focus on the genetics, even from a clinical perspective, we can start to guide our families and tell them how they will do surgically. So even if you master the surgery, even if you do a great reconstruction, regardless of the technique that you use, we have seen that patients with proximal hypospadias have more risks and do worse than distal cases. In this publication that I did, we looked at 24 years of data, and we saw that the more proximal the hypospadias were, the more likely it was that they would have another anomaly associated. And this publication from Fahad Al-Juraiba, he actually showed that extragenital anomalies are related to an increased risk or poor outcome after surgical reconstruction. So I think that explains the possible link between worst outcomes in patients that have a higher likelihood of having a genetic underlying condition. Patients with partial androgen insensitivity compared to just simply DSD 46XY patients with hypospadias do worse. And so I think we need to start to understand this way better. Proximal hypospadias, this is a very interesting publication from the group in Chicago, and they have been identifying the presence of genetic anomalies. And they started by doing 100% of karyotypes to their patients. And I think this is just a historical reason. Initially, karyotypes were the first line, and they continue to be, to explore for any genetic anomalies. And more recently, we have started to do genetic panels for these patients. And only 13% of this cohort underwent a genetic panel. But they found that genetic anomalies were present in 28% of the cases. That's a very high yield. And this is only with a panel, not with massive sequencing. So if we take a look at this, then we need to change the way we think. And this is a publication that I did where I was exploring a single specific gene, the MAM-LD1. And this was a recently discovered gene where we looked for the presence of any mutations in exome using single gene sequencing. And we found actually that there was a complete difference in the phenotype of these patients. So the interesting thing is, I think we're moving into, is hypospadias a phenotype that expresses differently and the underlying condition is a genetic one? I think it's maybe hypospadias a common phenotype of multiple different diseases. So when we start looking at the impact of genetics in outcomes, I think we can use this image to simply show how if we focus, and for example, pay our attention to the urethral plate and see how the expression is in that area of interest, we can probably look microscopically at that tissue, because that's the one we will be using for the surgical repair. If we do a tip repair, if we do a thirst to play repair, if we do any kind of flap rotation, that's the tissue that we're trying to preserve. But we have never explored about the quality and how that links to genetics. Um, so the potential genetic markers that can predict the outcome um, of surgical procedures has already been shown. We know that, for example, in idiopathic scoliosis, there are specific genotypes that show better or worse surgical outcomes. So genetic variants as predictors are already being used. For example, renal cell carcinoma, genetics are now guiding how we do surgery and how we do immunotherapy. Same for prostate cancer. So why not doing it for hypospadias? This is actually an in silico modeling of the MAM-LD1. And the interesting thing is you can see that it interacts with multiple different genes. And one of those is this one, the RBP1. And the interesting thing is once it interacts with that gene, we found out that in silico analysis showed that it's related to wound healing. So maybe this is where we need to start thinking, is this anomaly that we're seeing genetically a predictor of a malfunction elsewhere that will guide how we should be focusing our surgical repair? Maybe this patient with that mutation will do worse than other patients. And same with what I mentioned before, preoperative stimulation with testosterone. There's a lot of debate whether or not we should give it and if we should treat our patients preoperatively with testosterone. I think the conclusion of this meta-analysis from Michael Chua, who was my co-fellow at SickKids, and now he's an attending there, shows that they found that there was a subgroup of patients that would benefit from testosterone. Maybe this patients can be identified by genetic testing. And this is another interesting approach that I think we need to start looking at it. We have been focusing on the macroscopic tissue quality, but we have not identified the microscopic variables that can predict surgical outcomes. And we have started to see that ventral dartos is probably not the best to cover urethroplasty. You can see the difference between a circumcised healthy male on the left hand and a patient with hypospadias, and how there is a significant difference in the distribution of the smooth muscle. So if we're trying to reduce the rate of fistulas and we're using, for example, ventral dartos to cover that urethroplasty, maybe we're not using good quality tissue to cover it. And maybe we should be exploring other types of tissue, and that's why some surgeons support the use of tunica vaginalis, for example, or a more recent result from one of my studies that we haven't published showed that the distribution of the smooth muscle was more dense on the dorsal part. And ever since I found that result, I have been using dorsal dartos and rotated ventrally to cover the urethroplasty instead of bringing the ventral dartos up to cover it. And I haven't looked at the numbers yet, but I'm hopeful that just because of this change, patients will start to do better. This is another interesting factor that actually they looked at the distensibility and rigidity of the urethral tube that was formed after surgery. And they explored how the tension would show on healthy patients versus controls. And you can clearly see that the difference and the distensibility of patients that have undergone a reconstruction. The urethra, the more blue the image is, in other words, the more rigid it is. And this clearly explains that maybe the tissue that we're using, that urethral plate, may not be very good for the surgical reconstruction after all. And that may explain why some patients that undergo buccal grafting for the repair do better than the ones that have been using the urethral plate. This other study from Camoglio from Italy, he showed that with ultrasonography, you can also evaluate the rigidity of the tissue. And I think this is where I believe we should start moving forward. And this can hopefully at some point be done intraoperatively to guide how we should be selecting the tissue. And for example, if we choose a segment that has better quality with more elasticity compared to a harder area, maybe the patient will hopefully do better. And I think this is where technology starts becoming a key component. I think if we look at hypospadias and try to reduce that variability amongst surgeons and experience, and try to make it a more standardized way to classify hypospadias, I think we'll start doing moving into the next level. So this is a project that I recently published at the Journal of Pediatric Urology, where we used machine learning to classify hypospadias. And initially, we used almost 1,200 images of hypospadias. They were distributed between distal and proximal, and we classified them arbitrarily by 5 different experts who had seen the images. And then once we had classified them between distal and proximal, we actually fed them to the algorithm. And that algorithm that we had created learned how to identify distal hypospadias versus proximal hypospadias. And then we used 31 naive images that the algorithm had never seen and compared how humans would classify those 31 images versus the model. And interestingly, we found that if we trained the algorithm only with 627 images, it would have an accuracy of 60%. So there will be a 40% chance that the algorithm was not really learning appropriately. And if we kept feeding and repeating that teaching, it would generate a situation where the model would be learning only those images, and it would not be able to identify new images different than the ones that had been fed. And that's called overfitting. So we increased the amount of images that we were feeding to the algorithm, and it actually, with more images, reached an accuracy of 90%. When we compared that accuracy to the experts that classified those 31 images, we actually found that the model was doing very similarly to human experts. So in other words, I think we can now start using these algorithms to help us guide how we're classifying hypospadia. So we can now change what we fit to the algorithm and then improve how we classify hypospadias, and also see if that has an impact on surgical outcomes. And this is the output of that algorithm. We show the image, and the algorithm just shows the result of the input and confirms that with 90% accuracy, this is proximal hypospadias. Trying to then build up a more complex model, I moved into the next step, which was trying to see how we can improve the way we classify the curvature. And there has been a lot of debate. Initially, Carlos Villanueva, who's actually a friend of mine working at Phoenix, he explored how it was comparing, how it was the accuracy of comparing eyeballing, so looking at the curvature and subjectively saying, how severe the curvature was compared to how it was with a goniometer. And he actually published that there was a poor correlation between the goniometer and the ventral curvature, and it did not, it wasn't more accurate than eyeballing. So this starts to show that subjectivity on penile curvature assessment, it's very high. And I did a collaborative study with Carlos where we wanted to make this more standardized. So we used the same 3D printed models that he had used in his publication, and we developed an algorithm where we could semi-automate the way we would measure the angle. And we tried to generate this algorithm where we would use the picture taken from the model, and we just had to put the subjectively, so the person doing the assessment would have to place the cursor at the most distal end of the penis and another one at the most proximal one, and the algorithm would calculate by its own the angle. And so that we're hopeful that is the next step to reduce this variability. The benefit is that it's something that can be done intraoperatively on an image, and it will help guide more objectively the way we do the surgery. And in fact, this study helped us standardize the way we should be taking pictures in the operating room. We did analyze if the picture was taken from 0 degrees with the camera, at 15 degrees, 30 degrees, 45, and 60. And you can see that progressively we start losing the ability to really evaluate the curvature. We found that the most accurate assessment was between 0 degrees and 30 degrees. More than 30 degrees, you would lose the ability to objectively classify the curvature. So if we're going to standardize how we take pictures intraoperatively, it has to be between 0 and 30 degrees angles from the camera. And this is another thing. We only focus on the curvature, right? And we talk about curvature, but report it in angles. And this is where I believe we need to move into the geometry field and explore this a little more. So we would say we're going to measure the curvature or angle, and we highlight the dorsal curve that the penis has on a G-test test, and then we do the one on the dorsal part, and we would assume that it's a cylinder, but it's not an even cylinder. It's very different. So if we extrapolate the curves that I did and put them on the side, we can measure the angle on each one of them, but it's going to be different. And so maybe what we have to do is think about this in a different way. We maybe need to start thinking more into the geometry analysis of arc formulas and talk about more of curvatures than just simple angles. And I think this is where we need to start moving forward. So the initial semi-automated algorithm that we had created is actually a work in progress that we're now trying to explore. If we, instead of calculating the angles, calculate the curvature and how similar it is to a perfect circle. And I think this is going to be probably something that will give us more information in the future. So maybe we need to stop reporting in angles and maybe move more into curvature analysis following a Gaussian curvature principle. Another thing that I have been exploring more recently is how we can define the urethral plate. A surgeon with experience may be able to really tell the boundaries of the urethral plate and can really make a good decision to where he should do the incision. But maybe a surgeon like me with not so much experience requires more time to really define where the incision should be. This is actually a case that I did, and I was trying to see at this image to maybe define where the urethral plate was. And I think it can easily be seen that there is a very subtle line that delineates the urethral plate. So maybe people would say use that segment for the reconstruction, but it may be very narrow. So should we extend beyond that urethral plate? Is that tissue that we should be using? And we've seen that previously the use of tissues like the scrotum that were used in the past showed that they were not good quality long term because they would grow hair, for example. And I think we now need to start looking at a way to better assess the urethral plate. If we look at this image before, we can say this is probably a penile hypospadias. Some people would say it's penile, definitely. But this is penile as well. And see how different the anatomy is. The urethral plate is completely different, and you can tell how different you would plan your surgical repair. So there is great variability, and we cannot keep using the location of the meatus only and a subjective assessment of the urethral plate. So what I'm trying to say in other words is maybe we need to objectively assess the boundaries of the tissues that we should be using. This is a classic image of the book from Hadidi. I love this book. It has great drawings and sketches. And this is the example for the TIP repair, the Snodgrass repair. And you can see that you delineate the boundaries, you make the incisions on each side, but that's completely arbitrary. And it's hard to really know if you're doing the incision where you should. This project that I'm working on is actually looking at how we can define and do a mapping based on pixel analysis of the tissue. And so we used that initial image that I showed you and looked at the pixel distribution. And then we did a statistical analysis, and we used 4 different densities or colors of the pixels and tried to define if there was a tissue or a cluster of pixels that would tell me this tissue is different from this other, and do a mapping to identify if there's better quality or worse quality of the tissue. And you can see that statistically, the distribution of the tissue in the red area is probably a tissue that may be good or may be bad for the reconstruction, but you can tell that it's starting to anatomically define the skin that should be used for the repair. Maybe the yellow area has better quality. And I think that's where we need to move to the next level and see if we can map the skin that we should use. This is the same example that I showed you, but see how smaller the red area is. It's definitely that cluster of pixels is telling me that skin there, it's different. And maybe we should be analyzing these images preoperatively to plan where we should be doing our incisions. And here, it's the simple way to make it more evident. This is probably where some people would do their marking and their incision planning. But what about all those different areas? Should we include them in the reconstruction, or should we send them to pathology and not use them for the repair? Will that allow us to better delineate the anatomy? I think the pixel analysis will definitely help us in that matter. And so why are we doing surgery after all? Mild regret. So there's a lot of regret from parents about doing the repair, but maybe we use all the previous technologies and start thinking differently about how we should be doing the repair. We may be able to counsel families better. And maybe we have all been saying you can do this repair in 1 stage, 2 stages, but maybe we are doing on most of our patients more than 2 stages to complete the repair. And what is a satisfactory reconstruction? We don't know. So we need to include also how families see the anomaly. And hopefully, if we add classifications that include patient's perspective as well as family's perspective, we will improve the care of our patients. So I'm I'm sorry if this topic, this presentation did not focus on technical aspects only, but I think we need to be aware that we need to think differently about how we do the technical repair. I think it has been proven that there is no single technical surgery that will definitely be better than other. Some people prefer to do the thirst-to-play. Other people like to do stage repairs, tip repairs, uh, dig repairs. And I think ultimately the variability has proven that we need to look at the tissue differently. So in conclusion, if you're starting to build a new house, people do pay attention to the quality of the um, implements that you used for building the house. We have not looked at that. So should we continue to think on how to put bricks together, do the surgery, or should we maybe include what kind of materials are we using? Maybe we need to look at how do materials interact with each other, cement and bricks versus wood, and maybe start understanding how this surgical repair slash building a house responds to all those different variables, and how happy are people living in their houses. We need to understand if all our efforts ultimately are paying off, and patients are happy and having a normal lifestyle. I want to thank you all, and I'll leave the time for questions. Again, it has been a great honor to share with all of you, and hopefully we'll stay in touch for future presentations. This is a picture from Mount Rainier one day that I went out running, and it was really sunny. And I wanted to share with you that it's not the way people think here in Seattle. It rarely rains, actually. Thank you very much.
Thank you so much, Dr. Fernandez.
Thank you so much, Dr. Fernandez. За манайхнаас асуулт байна уу? Hypospadias-ийн талаар. Okay, I have one. За асуугаарай.
Сонсоог байж магадгүй. Гэхдээ энэ нэг hypospadias-тэй хүүхдүүд нь дандаа хугацаанд төвсөх хүүхдүүд байсан уу?
Okay, here's one question. The cases with the Hypospadias with kids, do they give a birth in time or like in preterm?
I'm sorry, can you repeat the question?
Okay. The kids with the Hypospadias, did they give a birth in time or in preterm delivery? Do you have any
difference?
Yeah.
I don't think so. I think the decision to do surgery in preterm babies versus full-term babies may not be completely impacted by that variable specifically. We know that premature babies have an increased risk of having hypospadias, but there is some evidence that has shown that that by itself is not a factor that will affect the surgical outcomes. And in fact, surgeries that have been done after the 18 months, as it is recommended by the AAP and the AUA, don't have any increased risk of complications after surgery. So age and prematurity alone do not affect the way we do the surgical repair. I think specifically if you have a premature baby and you're thinking of doing surgery, I would do the surgery not before the 6 months of corrected age. I've seen some surgeons that do surgeries earlier, but I would definitely not do it earlier than 3 months. And the only reason with no true evidence is we know that the penis grows in the first 3 months of life. So I would prefer to not do any surgery before that. And also, I would like to allow the patient to mature and not have any complications with the anesthetic.
Okay, thank you. За манайхан саяны хэлсэн зүйлийг ойлгосон. Ерөнхийдөө Дотоод төрж байгаа хүүхдүүд бол ерөнхийдөө hypospadias үүсэх эрсдэл өндөр байхын хувьд байдаг. Гэхдээ мис заслын тохиолдолд бол ерөнхийдөө fixed age гэдэг одоо нэг 6 сар яг би гүйц юунаас төр хугацаа гүйцнээс хойш 6 сарын дараа ихэвчлэн хагалгаа орвол зүгээр гэсэн байдаг. Эхний 3 сард хагалгаа орох юм бол хүүхдийн шодооны урт нь хөгжиж гүйцээгүй байдаг, бүрэн томорч гүйцээгүй байдаг учраас эхний 3 сар бол хагалгаа хийгээд хэрэггүй. Заавал дор хаяж 3 сараас хоошоо хагалгаа хийхдээ. Гэхдээ би бол ерөнхийдөө өөрөө 6 сартаас хоошоо хагалгаа хийдгээ гэсэн тийм хариултыг өгж байна. Тэгээд энэ 6 сартаас хойш хагалгаа хийхэд эрс хүндрэл бол харьцангуй бага. За дээрэс нь бага байдгаа гэдэг чинь. За өөр асуулттай юм байна уу? Okay, I have a question, Dr. Fernandez. Okay, there is several new the methods that you have been using in hypospadias surgery. For example, the elasticity of the grafts. It's really interesting for us. We never have this kind of testing in the grafts. How you really measure with the elasticity?
Yeah, that is a very good question. We have not, unfortunately, been using it on a clinical level, meaning we haven't been using it for patients in the operating room if they're not included in our research project. So far, this is preclinical data that we have not been applying clinically to do the repair. But I think the preliminary results that have been published have shown that there is a difference in the tissues. And the idea is having a way to choose more objectively the tissue that you're using. And I think we have all seen sometimes when we're doing the urethroplasty and we're folding the urethral plate, that there are urethral plates that are more mobile or more flexible, and you can easily do the suturing. If you can identify the ones that may be more rigid, for example, or may have a least probability to heal appropriately, I think that will guide how we should be picking our tissue. The way I foresee this applicability, I'm not sure how familiar you are with dermatology high frequency ultrasonography. The dermatologists use high frequency ultrasonography, and they can actually see the depth in the skin of any lesions that they're studying. So you can do ultrasonography for very small lesions, and you can define the tissue that you're exploring with those probes. If we can then move to the next level, and ultrasonography can also physically measure the tension and rigidity of the tissues, then we can then start using it clinically. So unfortunately, it's preliminary preclinical data, but I think moving forward, that's something that you can easily start doing. How I see this right now, I believe that that's the difference between a young surgeon that it's learning and that senior surgeon that has been doing it multiple times, and just by his own experience and unconsciously, he can identify which tissue is better than the other. And you can see a senior surgeon saying, you know what, let's do this, let's cut here or there, without really knowing how he chose that tissue, just his own experience and how he has learned throughout time. But if we can expedite that learning process and make that unconscious awareness, a conscious awareness to choose the tissues, I think that's where we will improve the surgical management of hypospadias.
Okay, I will translate the answers for the rest of our participants. За би сая бол ерөнхийдөө hypospadias-ийн талаар ямар суулгаж байгаа крафтуудын талаар одоо шилжүүлэн суулгаж байгаа хэрэгжилж байгаа шодон ойр орчмын тийм утсан арьснуудын талын одоо уян хатан чанарыг яаж тодорхойлж ийнэ вэ гэдэг зүйлийг асуусан. Тэрэн дээр нь Фернандес доктор бол ерөөдөө ихэнх одоо юутай туршлагатай олон жил мэргэжсэн эмчнэр бол ерөөдөө хаанаас ямар арьс ямар крафтыг шилжүүлэх вэ гэдэг зүйлийг мэдчихэдэг. Гэхдээ тэд нар яагаад гэдэг зүйлийг бол сайн мэддэггүй маа. Гэхдээ бидний одоо хийж байгаа судалгаа бол ерөөдөө клиникт бол яг хэрэглэгдээгүй байгаа. Клиникийн өмнөх туршилтан дээр явагдаж байгаа тийм зүйл байгаа. Энийг бол ерөөдөө хамгийн хялбар аргаар тодорхойлох арга нь болохоор тэр өндөр давтамжтай хэд 50 тусламжтайгаар энэ арьсны заад хойр орчмын авах гэж байгаа эдийн уян хатан чанар, зузаан чанарыг бүрэн тодорхойлох тийм боломжтой. Тэгэхээр энэ тэгэхээр ерөөдөө заслахтаа мис засалж байсан ч туршлагагүй залуу мис засал байсан ч ерөөдөө ижил хэмжээний одоо крафтыг суулгах тийм үр дүн өгөх тийм юм байгаа. Удахгүй энэ клиник туршилтанд бүрэн орох болов гэсэн тийм зүйлийг асууж хариулт өгч байна. За манайхнаас өөр асуух асуулт байна уу? Okay, I have another questions about the pixel analyze. What kind of camera do you use in pixel analyze in there?
I love that you're interested in that. I think the way I have been learning about this is I had no idea about artificial intelligence, machine learning, and I have slowly started to get involved in this project. And initially, when I met with the engineers, they wanted me to use a very specific camera, high quality camera, in a scenario that you could control the light exposure, the focus, the quality of the image. And I wanted to avoid that because most of us take the pictures with cell phones and maybe not so standardized. And if we were to do a research project with such a complex setting, nobody could replicate that in real life. So the machine learning project that I did, the one where we classified hypospadias using the algorithm, we actually used pictures that were not completely standardized, meaning you were taking with different types of cameras, we're taking from different distances, we're taking with different exposure to light, and that we proved that we don't need to standardize it so much. The next level is using that same set of images, and we are now analyzing the images for the pixel analysis. And the pixel analysis is being done with a software that can look at the distribution of pixels and find statistically if that specific color generates clusters. And you can also look at how smooth the skin looks, for example. And to answer specifically your question, you can use any camera. My phone is actually what we use. There has been a lot of debate about how we should be taking pictures. And more recently, we have been using HIPAA compliant cameras or apps that will go straight to the patient's chart, medical chart, without going through our phones. So we're not saving any genital images in our phones, and it goes straight to patient's chart. And I think the more images we have, we may actually need to collaborate with many surgeons to collect enough images to do the studies. You can see that I had to use 1,200, so 1,200 images to do the analysis of 1,200 different patients. So we need large data sets to do this analysis. So for the pixel, any kind of camera, any kind of light exposure, we're hoping that this will be applicable in real life, hopefully soon.
Okay, thank you. За манайхнаас өөр асуух асуулттай хүн байна уу? Саяны хариултын хувьд бол би нөгөө pixel analysis гэдэг байгаа. Түн дээр hypospadias үед ямар төрлийн арьсыг ямар камераар авдаг гэдэг асуултыг асуусан. За энэ дээр бол ерөнхийдөө ямар ч төрлийн камер хэрэглэж болно. утас байж болно. За тэгээд тэрийг болохоор тодорхой програм руу шилжүүлээ 6 явуулаад тэр програм нь болохоор анализ хийгээд анализийн үндсэн дээр одоо тодорхой арьсны чанарыг бүрэн тодорхойлж гаргадаг тийм л зүйл юм байна. За өөр асуулттай хүн байвал асуулт асууж болно.
За хоёроо ч үг хэлчих үү?
Okay, here is our the head of our department, the Dr. Bayingunder, Professor Bayingunder is connecting to you.
Very nice to meet you. A real honor.
За өнөөдөр одоо өнөөдрийн энэ сургалтыг зохион байгуулж байгаа доктор Nicolas Fernandez болон манай IVUmed координатор Кати нартай их баярлж байна.
Thank you for organizing these lectures for Mongolian urologists, the coordinator Katie and Professor Dr. Fernandez.
За өнөөдрийн
No, you please go ahead.
Өнөөдрийн сэдв бол их чухал сэдв байсан. IVUгийн одоо Catherine DeVries гээд профессор доктор маань Монгол улсад 2006 онд эрэхтэй хамгийн анх энэ гипспадийн месослыг манай амьтаг дээр 2 хүнд хийж ирсэн байгаа.
The first IVU doctors, the Dr. Catherine DeVries, is visited in 2006, and she performed the 2 cases of the Hypospadias surgery in Mongolia in our hospital.
Тэгээ энэ үед бол бидний хийсэн месослууд бол маш олон дахилттай. Зарим тохиолдолд 4 удаач хүртэл месослын дахичихсан ийм хүнд тохиолдлууд бол байсан байгаа.
During that time, we have experienced a lot of the recurrence of hypospadia and other failure of hypospadia surgery.
Тэгээд энэ IVUгийн докторуд ирснээс хойш бол манай энэ урологийн практикт энэ 2 үе шаттайгаар гипспадийн мэслийг хийх, мөн бакл графт ашиглаж хийх гэдэг энэ мэслүүдийг хийдэг болсноос хойш мэслийн дараах тахилт бол байхгүй болсон байгаа.
Since the IVU doctors visited in Mongolia, 2-stage hypospadias surgery we started to perform, and also the buccal graft surgery perform. Since that we have faced the less complication, the less post-operation complication.
Тэгэхээр энэ манай хүүхдийн урологуудын хийж байгаа мэслийн арга нь бол сайжирсан гэж бодож байна. Яагаад гэвэл насан туршид дунд бол гипспадийн ийм эмгэгтэй хүмүүс одоо биднэрт хандхаа бараг болсон байгаа.
Okay, since that nowadays we do not face less hypospadia patients in adult because of our the pediatric surgery experienced highly in hypospadia surgery. That's why we have less hypospadia in adult case.
Тийм, өнөөдрийн энэ лекц бол генетиктэй холбож маш өндөр суурьтай гипспадийн одоо өвчний суур үндсэн зарчмуудыг агуулсан их сайхан лекц боллоо. Тэгээд Фернандес доктортой маш их баярлалаа. Тэгээд дараагийн лекцүүд бол манай урологийн эмчнэр одоо хүсэн хүлээж оролцох болно. Ер нь бол жилдээ 2 удаа IVUгийн баг ирдэг байсан. Одоо бид одоо ингээд сардаа 1-2 удаа ингээд бүр уулздаг болсон бүр одоо онлайн хувьд мэлгээ дэвшлэхэд маш их аж тустай байна. Тэгээд та бүхэндээ баярлалаа.
Okay, today's lecture is very important, and also you were included in the genetic importance for the hypospadia. And normally we do meet the IVU doctors in two times in a year, but nowadays we like every month we have a meeting with the IVU doctors. That's a really great pleasure to having you guys.
Well, yes. So really thankful for your words. I think you made really important points. The first one is that you learned from someone that visit how to do the 2-stage repairs. And it happened to me actually. I did my residency in Colombia in South America. And I remember back then when I was probably not a resident yet, but maybe a medical student, we had the honor to have Ivar Braca come and do surgeries in Colombia. And he showed us how he was using the buccal graft for the repairs. And I think we were very lucky to learn from him at that point early on, and that must have been in 2006 maybe, the importance of the two-stage repair. And I think time has proven that this is a very good surgery for proximal hypospadia. So I'm glad that you are doing it. And I think we definitely have proven indirectly that using a different tissue, not the urethral plate, can sometimes improve surgical outcomes. And definitely, I think moving forward, if we can make this more objective, it will be critical. Another thing I wanted to just share with you is I grew up in Bogota, which is the capital in Colombia. And that city, it's located at 2,600 meters above sea level. It's very high. And I did a study there where I looked if the altitude would impact on the prevalence. And I actually found that higher altitude cities had lower prevalence rates of hypospadias. And I did look before the presentation if Ulaanbaatar was at what level it was, and it's I believe 1,300 meters above sea level, and that's the
Yes, it is.
level where we started seeing that there might be less risk to develop hypospadias. So I would be interested in knowing if you have less cases than other parts of the world just because of that, that probable protective effect of high altitudes. And it would be interesting to see if we could collaborate in the future and do research studies together.
Yeah, that's great. За Sirgit Fernandez доктор сүүлийн хэлсэн гол санаа нь юм бол өөрөө Колумбийн нийслэл төрсэн. Энэ далайн түвшнээс 2300 орчим метр байдаг. Энэ үед судалгаануудаас харж байхад ерөнхийдөө далайн түвшнээс дэш 1300-аас дээшээ орон нутгийг болохоор Hypospadiaгийн тархал тохиолдол нь бол харьцангуй бага байдгаа гэсэн хэмжүүнийг ярьж танилцууллаа. За манайхнаас өөр асуулт байхгүй бол ингээд лекцээ дуусгах уу? Okay, we don't have any question, and here we are going to finish our lecture for today. Hope you will soon, in virtually or in the body to body.
Yes, that would be fantastic, and I would love to get to meet you all here. The doors are open for you as well, and I'm hopeful that we can continue to be in touch.
Yep, for sure.
Thank you so much, everyone. And thank you for presenting the 3 lectures, Dr. Fernandez. We really appreciate it.
Yeah, let me know if there's any way I can help you.
Okay.
Thank you.
Bye, everyone.
Thank you, Katie. Thank you, Katie.
Thank you.
Bye-bye.
Bye.
Thank you.